Hi, Jennifer.
Yes.
Hi, Jennifer. I'm John Rodriguez. I'm the RN coming on. I understand you're a student nurse.
Yes,
Great. And you've been working with this patient, Tim, here?
I have.
Okay. Why don't you go ahead and tell me what your report has so far?
Okay, this is male, 10 Doherty, age 38, birthday 10/5/71. He was admitted to the ER 2 days ago to 2210 for respiratory failure from a motorcycle accident and chest injury. He's currently on a ventilator assist, and we DC Versad per the physician order to prepare for a daily sedation vacation to prep for breathing trial. He's going to be placed on spontaneous breathing trial. Yes. He's alert and oriented ×3, isoperla, blood pressure 138/86, temp 99.3, pulse 77, respiratory 22. His pulse ox is 100% over 3 liters. His legs have +2 edema bilaterally, meaning he has scuds on.
Okay.
Currently, his pain's about a 5/10, and he's being treated with morphine 4 milligrams every 4 to 6 hours.
Is that managing his pain?
He's tolerating the pain at a 5.
Okay. So how long have you been working with ventilator patients?
This is actually my first time.
Okay. In a nutshell, I don't want to put you on the spot, but this is a learning environment, so why don't you tell me what you do know about ventilators, and then patient care on ventilators.
Okay, I know ventilators assist with the breathing, but the patient cannot do it on his own or have difficulty keeping up with the oxygen level.
Okay.
I know that I need to turn the patient in 2 hours, provide oral care every 4 hours.
Okay.
And I know that there is suctioning done when it's needed, and the RT comes in and sucks as well.
Okay. Awesome. Anything else? Okay, so let's highlight and talk about some of the things that you just mentioned. Yes, he's on a ventilator and ventilator assist. So his respirations can fall into a couple of categories. A, he's not respirating enough times per minute, or the volume is not enough for proper gas exchange. Okay, so basically there are 2 types of ventilators: positive pressure and negative pressure ventilation. And he's on a positive pressure ventilator. Okay, so what we're doing is we're having the machine expand and deflate his lungs. Basically, they're taking the place of his diaphragm. Okay. Now, the rate at which we do that depends on a couple of things. The rate that we're doing it for Tim right now, he's prior to this the motorcycle accident, he was a healthy individual, very athletic. So we want to get him back to our ideal respirations. We're going to call that 10 to 12 per minute right now. Okay. The rate at which we do that is relative to how well he's perfusing, meaning the gas exchange. So we look at his oxygen monitor saturation, and you told me he's getting 3 liters a minute and 100%. So that information right there tells me that A, we're ventilating him adequately, and we're providing him with enough oxygen. All right. So backing up from that, the Versed, he had been sedated on Versed, and the physician's orders were to discontinue that. Okay, so the daily sedation vacation reflects upon our patient as a whole. What we want to do is get this patient, all patients on ventilators, off of ventilators. What we don't want them to do is become so dependent upon that ventilator that they're unable to come off. So what we do, and the CDC, you familiar with CDC?
A little bit.
Okay, CDC set out some protocols, and some of those protocols are daily sedation vacations. So what that means, we're going to stop the sedation. We're going to switch his vent assist to spontaneous breathing. And what we ultimately want him to do is to start breathing on his own. And if we can get him setting up, he can still exercise. You know, meaning that if we can get him to sit on the edge of the bed while he's off on the vacation, meaning spontaneously breathing on his own, and we'll see how he tolerates that. He may or may not, which means he'll go back on the ventilator, or ultimately we can extubate him. Okay. Beyond that, the suctioning and the oral care and the care that you just said to me is spot on. CDC recommends oral care every 4 hours. It's tough to do when he has that tube in his mouth. Oftentimes, another type of intubation. Basically, when they're performing the tracheostomy, it's an artificial airway. and just like the intubation tube is an artificial airway, we're going to hook that up to the ventilator, possibly even supply some oxygen to him that way, and potentially a type of feeding for him as well, so he can maintain nutrition. You mentioned something earlier, Jennifer, about in your report about oral care and suctioning. And those are all really big components and really, really critical for the ventilated patient. Yes, respiratory therapy does come in and they do perform some suctioning, and there's two types of suctioning that we can use here. One is with this suctioning here, we'll actually go down into the tube and remove secretions out of that. Another way we do that is with a cannula. We can get just what's inside his mouth and outside his buccal muscles there. In addition to that, the oral care that we give the ventilated patients, it's at a minimum of every 4 hours, and for a couple of reasons. We want to maintain hydration in the oral mucosa, but also we want to remove any secretions that the patient can't get out. If they're having difficulty coughing, say, that's what the two types of suctioning do. And with the oral care, we can actually hook and pull some of that material out. And it just feels good for the patient. They're really critical in the prevention of VAP, ventilated associated pneumonia. And that is the leading cause of infection for all ventilated patients is ventilated associated pneumonia. And it accounts for 50% of all the antibiotics used in the ICU. So it's really critical that we minimize their exposure. I mean, basically what we've done with the endotracheal tube and the tracheostomy is provided direct access into the lower respiratory tract, and it's just a great place. It's warm, it's moist, it's a great place to incubate microorganisms and create complications thereof. The CDC, in conjunction with Joint Commission, has determined that VAP is a preventable disease, and so what that means to us as nurses, respiratory therapists, physicians, is that in the hospital, is that dime is on us. So, you did a great job on your report there. Regarding the edema, that's a good pickup on your assessment, because oftentimes what happens with the ventilated patient is we give them fluid overload. In Tim's case here, it's a trauma patient, but we still have to hydrate him. We still have to monitor his IV input, his nutrition input, and certainly his output, bowel movements, that stuff. Head-to-toe assessments, do you tell me about his lung, do you tell me about his edema? Those are all great indicators as to how well he may or may not tolerate the extubation ultimately, but these treatments we're about to do. So I think what we'll go ahead and do now is get a hold of respiratory therapy, have him or her come in and get ready to suction this patient, and I'll go ahead and continue my assessment, head-to-toe assessment. I can chart all of that, and you can have all that information available to you. Thank you so much for contributing to the care of this patient and for your report. Very thorough. Thanks a lot. Enjoy the rest of your day.